Older adults can present with non-specific symptoms, and sometimes the devil is in the details. This case reminds us that sometimes we have to look beyond the more obvious causes.
A 75-year-old woman was admitted to the hospital for investigation of night sweats and a 4-month history of unintentional 8-kilogram weight loss. She denied fever, arthralgia, cough, diarrhea, and abdominal pain.
Weight loss and night sweats can be caused by malignancy, autoimmune or inflammatory conditions such as vasculitis, or infections such as tuberculosis. Common hematologic malignancies in people of this age include non-Hodgkin's lymphoma, chronic lymphocytic leukemia, and multiple myeloma. All could present with these symptoms. Solid organ tumours can also present similarly. Giant cell arteritis is a key concern. The patient should be asked about a history of headache, jaw pain, or blurred vision. Hyperthyroidism and systemic lupus erythematosus, SLE, should also be considered.
The patient had been diagnosed with diabetes mellitus 4 years earlier and had associated microalbuminuria. Diabetes was well controlled on metformin. She did not smoke, consume alcohol, or use illicit drugs. She lived alone and was a retired cook. The patient reported no sick contacts or exposure to animals. She had not traveled abroad in 6 years. Her last trip had been to Morocco, where she was born. On physical examination, the patient looked well. Her vital signs were normal, except for mildly elevated systolic blood pressure. Fundoscopy revealed no signs of retinopathy. There was no thyromegaly. Heart sounds were normal. There was a grade 2 systolic murmur heard over the apex. The lungs were clear. The abdomen was soft with no organomegaly. There was no palpable lymphadenopathy.
Tuberculosis is common in Morocco, increasing suspicion that tuberculosis may explain her symptoms. Her murmur raises concern for infective endocarditis, which also could cause weight loss and sweats, although no fever was present. Other infections and inflammatory and malignant diseases remain on the differential.
The hematocrit was low. Mean corpuscular volume and red cell distribution width were normal. White cell count, platelet count, and blood smear were normal. The erythrocyte sedimentation rate was elevated. The blood urea nitrogen and creatinine levels were elevated. They had been normal when last checked 4 months earlier. Electrolytes, liver function tests, calcium, albumin, and total protein levels were normal. Hemoglobin A1C was 6.9%. 1+ blood and 3+ protein were present on dipstick urinalysis. Examination of the urine sediment showed a few red cells but no casts. The ratio of protein to creatinine and the ratio of albumin to creatinine in the urine were elevated. 2 sets of blood cultures were sterile. A chest radiograph was normal. Abdominal ultrasonography showed normal-sized kidneys and no hydronephrosis.
This 75-year-old woman had evidence of normocytic anemia, new renal impairment, and nephrotic range proteinuria. Diabetic nephropathy is a frequent cause of proteinuria. But in this case, the heavy proteinuria, increased creatinine, and systemic symptoms raise concerns for another glomerular disease, such as membranous nephropathy, which can be associated with solid malignant tumours, or minimal change disease, which can be associated with Hodgkin's lymphoma. Another possibility is kidney disease related to a monoclonal gammopathy, for instance, multiple myeloma. Vasculitis could also underlie kidney disease. The normal chest X-ray makes tuberculosis less likely, and the negative blood cultures make endocarditis less likely, though do not exclude it.
CT of the chest, abdomen, and pelvis was performed without contrast given her renal insufficiency and showed no masses or lymphadenopathy. Anti-nuclear antibodies were positive at a low titer. Testing for anti-double-stranded DNA, anti-Rho, anti-Law, anti-Smith, anti-RNP, ANCA, Cryoglobulins, rheumatoid factor, and hepatitis B and C were negative. Complement levels were normal. A polyclonal pattern was seen on serum and urine immunofixation.
Testing has ruled out hepatitis and monoclonal gammopathy. Her CT does not show evidence of cancer or infection. SLE is unlikely given the low ANA titer, negative anti-double-stranded DNA, and normal complement levels. The negative testing for ANCA is inconsistent with an ANCA-associated vasculitis.
After a kidney biopsy, the patient was discharged with planned nephrology clinic follow-up. 3 glomeruli were seen in the sample, which showed mesangial proliferation and an interstitial infiltrate of lymphocytes and plasma cells. Immunofluorescence staining was positive for mesangial IgG, IgM, and C3. Electron microscopy showed subendothelial electron-dense deposits, and podocyte morphology was preserved.
Only 3 glomeruli were sampled on this kidney biopsy, in contrast to the recommended 8 to 10, limiting the diagnostic utility. IgM, IgG, and C3 deposition in the mesangium indicates an immune complex process. Mesangial and subendothelial electron-dense deposits suggest, but are not diagnostic, of membranoproliferative glomerulonephritis, or MPGN. Several conditions can trigger MPGN through immune complex deposition, including chronic infections, monoclonal gammopathies, and autoimmune diseases. Some typical findings of MPGN on light microscopy are not seen here, but may have been missed given the scant biopsy specimen.
At her follow-up appointment, the blood urea nitrogen and creatinine levels had increased further. A 24-hour urine collection contained 7 grams of protein. Hematocrit remained low. The white cell count was normal, but the percentage of lymphocytes was low. 60 milligrams daily of prednisone was started.
Glucocorticoids were started to treat a presumed diagnosis of idiopathic MPGN.
2 weeks later, the patient returned with fever, chills, and dysuria and was admitted to the hospital. There was an increase in her blood urea nitrogen compared to 1 month earlier, and her creatinine remained elevated. Urine and blood cultures grew Salmonella enteritidis. The patient reported 2 episodes of diarrhea a week earlier and recalled consuming undercooked eggs bought directly from a farmer near her home. She was treated with IV ceftriaxone, and the dose of prednisone was reduced. She had rapid improvement in symptoms and resolution of fever. Repeat urine and blood cultures showed no growth. A non-contrast CT scan showed perinephric stranding of the left kidney and atherosclerosis in the aortic arch and descending aorta. No endovascular focus was noted, but may not be appreciated on non-contrast CT. IV ceftriaxone was changed to oral amoxicillin for discharge, with a plan for a total of 6 weeks of treatment.
Eating undercooked eggs is a recognized risk factor for Salmonella infection. Use of high-dose glucocorticoids makes invasive disease more likely. The gastrointestinal tract is the most frequent source of Salmonella bacteremia. In this case, the presence of urinary symptoms, the positive urine culture, and perinephric stranding of the left kidney suggest an ascending urinary tract infection, which is much less common. In an older patient like this one, the identification of non-typhoidal Salmonella bacteremia warrants imaging to exclude endovascular infection.
2 weeks later, the patient returned for care and reported a new pruritic rash. Skin examination revealed an erythematous and violaceous rash, most pronounced on the back, arms, and feet, with small plaques, scaling, and desquamation. Repeat blood count did not show eosinophilia.
Drug-related xanthums can occur with beta-lactam antibiotics, but does not typically feature plaques, scaling, or desquamation. Considering this patient's original presentation with night sweats and weight loss, this rash raises concern for vasculitis, or cutaneous T-cell lymphoma. Vasculitis is more likely given her renal abnormalities.
A skin biopsy was performed showing clusters of lymphocytes in the upper dermis. Polymerase chain reaction analysis to detect T cell receptor gene rearrangement revealed a monoclonal T cell peak. A peripheral blood smear was normal. A bone marrow biopsy showed a hypercellular marrow without evidence of malignancy or myelodysplasia. No amyloid was detected on Congo red staining. The patient was referred to the hematology clinic.
The finding of a monoclonal T-cell peak may suggest a diagnosis of cutaneous T-cell lymphoma, but can also occur in healthy older patients and in patients with benign skin diseases.
Before the patient could be seen at the hematology clinic, she returned with recurrent fever and chills and was readmitted to the hospital. Urine and blood cultures again grew S. enteritidis. The patient reported that she had not completed the course of amoxicillin and that she had eaten more eggs from her neighbor's farm. TEE showed no valve vegetations. A PET scan showed no signs of endovascular or other infection. Abdominal ultrasonography showed no gallstones.
The patient's non-adherence to antibiotic therapy and continued egg consumption are plausible explanations for her recurrent salmonella infection, but testing was prudent to rule out a persistent focus of infection. Another reason for predisposition to recurrent non-typhoidal salmonella bacteremia, however, is AIDS. Given the unexplained kidney disease and the rash suggestive of cutaneous T-cell lymphoma, HIV infection should be ruled out.
HIV serology was positive. Viral load was 156,000 copies per milliliter. The CD4 count was 110 per cubic millimeter. Serologic testing for adult human T-cell leukemia lymphoma viruses types 1 and 2 was negative. Antiretroviral therapy, or ART, with abacavir, lamivudine, and dolutegravir was started. Sexual history and history of other risk factors for HIV were assessed after diagnosis. The patient reported that her husband had died suddenly 10 years earlier. She did not have information on his medical history. She denied having had sex with other partners and did not recall having received any blood products. 6 months after the initiation of ART, the viral load was undetectable, the patient felt well, the rash had resolved, and renal function had improved.
The positive testing for HIV infection, low CD4 count, and recurrent salmonella infections are consistent with a diagnosis of AIDS. Her nephropathy and rash are also consistent with this diagnosis. The low CD4 count and the presence of complications that are late features of HIV infection suggest that she probably acquired this infection many years before presentation. When this 75-year-old woman first presented with weight loss, night sweats, and anemia, the primary concern was malignancy. Presumably owing to her age, HIV infection was not considered. Frequently, a sexual history is not obtained from older adults. Some physicians might feel uncomfortable addressing this subject. Moreover, the sexual history may not be accurately reported by patients owing to concerns of stigma. Although the sexual history in this case was unrevealing, it remains a relevant part of the history even among older adults. HIV screening is routinely recommended for people who are 15 to 65 years of age. Approximately 5% of new HIV diagnoses are made in people over 65 years of age. This case underscores the need to routinely consider the possibility of HIV infection in patients with suggestive signs and symptoms, regardless of their age. Funding for this video is provided by the Doris Duke Foundation, committed to building a creative, equitable, and sustainable future.